pressed, you will get unmuted for that particular time.
Oh, good one.
Okay.
We are on.
Shyam, can you, Ashok, can you just adjust the screen because half of the screen is going in for the talk.
In what? So everybody can adjust their own screens.
Okay.
You have control of your screen at least. I mean, adjustment of panel.
So there's a way to do it. If you go to the top of your screen, you'll say view options. And in view options, if you just side by side, you will get everything properly arranged.
Okay, fine. I got it. Yeah. Hi, Anil.
Okay, sir, we are going live now.
Yeah.
Hello, good afternoon, everyone. I welcome you all, Vidarbha Orthopedic Society members and esteemed panelists from all over the country. Today's webinar is on open fractures, and Dr. Nitin Kimmatkar, our would-be secretary, is going to moderate it. I welcome Dr. Sunil Kulkarni from Miraz, Dr. Abhay Elhans from Jodhpur, Dr. Amit Asgavkar, my friend from Mumbai, Dr. Harshad Argekar from Mumbai, Dr. Deen Dayalan from Coimbatore, Dr. Rajiv Chatterjee from Kolkata, Dr. Rajiv Raj Chaudhary from Surat, Dr. Anil Masand, our local flavor from Nagpur, Dr. Mahendra Kale from Akola. Welcome all of you. The rules of the game are already known. I request all the panelists to keep your speaker on mute mode. Please raise your thumb or hand whenever you want to barge in and you want to defend your own case. The screen share is only with Dr. Nitin Kimmatkar, and he will run the entire show for all of us. If we all contribute as panelists, we will get maximum out of this webinar. So welcome and thanks for joining us. Over to you, Nitin.
Good afternoon, everybody. I welcome you all to the Vidarbha Spotlight webinar on case-based discussion on open fractures. Let us start with the. So what are the goals or objectives to manage open fracture? Basically, open fracture is a soft tissue injury with a fracture. So we need to manage soft tissue injury very well. Second goal is to minimize the risk of infection, stabilize and repair the skeletal injury, and restore the function of the affected extremity. So generally, these patients of open fractures are multi-trauma patients because of the high energy trauma. So multidisciplinary team approach is needed for resuscitation as well as some orthopedic and plastic surgery procedures. Accurate systemic stabilization of the patient should be done before taking any of these patients for the surgery in the form of lactates as well as ABGs, and adequate blood transfusion measures should be given to these patients in the form of PRCs, platelets as well as fresh frozen plasma. These patients should be clearly investigated in the form of neuromuscular structures which are in close proximity. So detailed examination of the limb as well as patient in question should be done. So coming to the first case, this is Dr. Abhay's case. So he should proceed with this case.
Okay, so we had a 38-year-old male who sustained an injury, a road traffic accident, and he presented to the emergency with pain, deformity, and open wound over the right forearm, the right thigh, and the right leg. And so these are the pictures of what the patient presented with. So you'd like to take the discussion, Nitin?
Yeah. So these are the injuries which are there. You can describe the injuries.
Yeah, so the patient had an open grade 3B shaft of the tibia fracture on the right side. He had a 3A shaft of the femur with a segmental fracture on the same side, and he had a both bone forearm fracture, a grade 2 open both bone forearm fracture, and he had a pelvic injury, which was an open book ABC type 2 injury, but without any distal neurovascular deficit.
So in these types of patients, how do you proceed in your trauma center at AIIMS Jodhpur?
So the first thing that we are looking at doing is doing the ATLS. So there are two important things in this criteria. Obviously, this patient has major skeletal trauma, and obviously this patient he's lost a lot of blood. So we'll be doing our ATLS protocol. We'll be doing the initial hemodynamic stabilization of the patient. We'll get two large bore needles in, and do the stabilization, do a preliminary assessment, and set up the IV lines, and at the same time assess the level of the open injuries, assess for any neurovascular damage. And once the patient is stable, our emergency and our radiology is just next doors. So even while this triaging is getting done, if the patient is stable, we can take the patient to X-rays, do our CTs, and then manage it as we would in a trauma center situation. But the important thing we always keep in mind is what is the type of open injury, what is the level of neurovascular deficit, what is the degree of contamination, and most importantly, hemodynamically, how is the patient.
So what sort of massive transfusion protocol you follow for the benefit of delegates?
So we have the trauma team which takes over the patient initially, and the protocol of the crystalloid and colloid follows the ATLS protocol. And it's not necessary that even in these open fractures, they would need a massive transfusion protocol.
Okay.
So we understand that currently the recommendation is that you replace the loss with blood, but still, there are lots of takers for both sides who will prefer to use the colloid-crystalloid combination and at the same time use blood as well. So different centers have different takes on how they will approach the patient.
So how do you plan to manage this patient? Whether you will go for DCO or something like an early total care?
So the first thought process essentially is the DCO, because the issue with early total care is that it was initially propagated as something that if you are able to manage the bony injuries early enough, the results and the functional results down the line are better. But subsequent literature proved very clearly that it should be either an early appropriate care or a damage control, wherein we take care of the hemodynamic stability of the patient. We do a soft tissue management and the initial stabilization, skeletal stabilization of the bony injury. And once the patient is stable, then rather than go in and immediately perform a surgery and give the patient a second hit because of the surgery, let the patient settle down and then triage the fixation of the skeletal trauma. At the same time, deal with if a patient needs a plastic reconstruction for the soft tissue injury.
Okay. Now you can carry forward. I will show these X-rays.
Nitin, can I ask a question, please?
Yeah, sir.
Anybody amongst the panelists who would do differently than what Abhay is doing at his place in AIIMS? For example, Didi, what are you doing in Ganga? Are you doing the same way or do you differ in any way?
No, whatever he said is right only, but the only thing is basically like lactate level estimation is the key. We need to make sure that lactate level is correctly estimated, make sure what is the occult type of perfusion is there. Based on that, you decide. But because it's injury is so severe, it's always better to go in for DCO in the beginning. So
Absolutely.
Now literature, everything has proved that DCO is a better option than to go ahead and do everything altogether. So,
Absolutely.
because pelvic injury has to take precedence, because it's an open book type and then he is going to bleed. At least if not now, Sometimes when he is shifted to CT or sometimes when he is shifted to the theater, again, there may be some bleeding because of the movements. We have to be very careful. So moment these types of patients come in, we always take them to the anti room, and then the CT, everything is done, and then made sure that DCO is done.
Okay. Sunil, any suggestions? Sunil Kulkarni?
The at level we have started doing it, but now it is the main thing is what you are absolutely right, that blood transfusions and DCO is important. But if possible, I can stabilize these femurs because this is necessary because they are the going to give more blood. If he would have landed in ruptured some pelvic injuries, he would have died there itself on the road. But it is survived. So that means the pelvic injury is not, though it is open book, but there may not be a bleeding. So rather I would go for a femoral and external fixator for the pelvic.
No, Sunil, as rightly pointed out by DD, there may not be active bleeding at that point in time, but he is likely to, start.
But if you see the history, it is already one day old, right? Isn't it?
Yes.
So this is 1 day old. The thing about the open book pelvises and the APC injuries is that if you see a lateral compression injury versus an APC, the APCs essentially are associated with hypovolemia, and they essentially are injuries where the patient will bleed into the pelvis. So if at one point in time with a grade 2 injury, the patient is stabilized, we should not just rest on our haunches, but just be very, very careful, because a lot of these patients sometimes will have an innocuous continuous bleed. So if these patients are, after we've stabilized the limb injuries, and we still feel that despite the resuscitation, the patient is not coming up, then our index for suspicion for other systemic involvement as well as an ongoing pelvic bleed should be very low. The threshold to assess and intervene should be very low, because these are patients who will definitely, the APC ones, unless if they have an ongoing bleeding, then they can decompensate very fast.
Okay. So you use a C clamp or some sort of pad or something? Or anybody
it's very it's an absolutely proven thing that if you have an APC2 injury without which is rotationally unstable but vertically it is stable, then you do not need to use a C clamp. So a pelvic binder, and not even the classically commercially available binders, a binder made out of a sheet which will extend from just superior to the iliac crest to the to just inferior to the tip of the greater tuberosity, and with the it is folded with the limbs stretched out, internally rotated and folded and firmly applied, is as good a stabilization device for the pelvis as any external fixation. And there's enough literature now to say that it does equally well. So if my patient is stabilizing after the stabilization of the limb trauma, and there is no ongoing continuous persistent hypovolemia, then I will not be in a rush to fix and stabilize an APC2 injury.
Okay.
So we can what you do based on the open injuries as they are. So as this patient has both a segmental femur, open segmental femur, open comminuted wedge, mid lower third junction tibia, as well as an open both bone forearm. So my priority here may not be to just rush in and fix the pelvis. A pelvic binder will do an equally good job for me.
Okay.
Let's move on. Nitin, let's move on.
Yeah. So everybody agreed on this, that this is the patient of the stage management. So how did you proceed, Abhay?
Yeah, so if you can go down to the next slide. So those are the basic questions we asked. So this is what we did. So on day 0, we did a debridement and an external fixator application for the tibia and the femur on the right side. And plus we did a debridement and a slab for the both bone forearm of the forearm injury, and got an opinion from the plastic surgeons. So they went in and they did a transposition flap on day 5 for the right limb, and the pelvis had a pelvic binder. So these are the X-rays. So this is what we did on day 1. And the patient got a flap for the tibia. And then we went in the second week when the patient was stabilized, and went in and did a fixation of the SI joint and the both bone forearm in one sitting, both posterior and anterior. And then we staged the treatment of the femur and the tibia. So we waited for about 6 weeks for the healing of the tibial wound, and we did a removal of the nail, and did a fixation and grafting for the femur wound, which was clean and healthy. And then we went in later down the line and did a treatment for the both bone leg.
Okay. So these are the X-rays. This was the final follow-up. So what is the message from this case?
So the message is that it's the most important thing in a polytrauma situation with an open injury is to do a preliminary good assessment and do a hemodynamic stabilization. And basically the thought process and the philosophy has to be damage control. Where the open injury, the neurovascular status, the hemodynamic stability and safety of life, and the management of the open wound has to take priority. In the meantime, one can do a skeletal stabilization with an external fixator for the long bone fractures. And the pelvic injury, unless there is an ongoing bleed, can be very safely and very efficiently stabilized with a pelvic binder. And we should learn how to put a pelvic binder correctly, because it is as good as a fixation device when in these kind of situations.
Yes, Amit sir.
Abhay, did you have any infection in the open injuries, in the grade 3 open injuries?
We did have some discharge initially, but the femur stabilized easily. The tibia did have an ongoing discharge, which needed a debridement when we fixed the femur.
What was your protocol in treating the open injuries as such? I understand the external fixators and then the definitive treatment, but then the open injury part of it.
So the basic thought process was we did an initial debridement. And on day 5, it was taken up by the plastic surgeons for a flap on the tibia. So at the same time, we used the opportunity to do a relook debridement if required, if the wound is not shaping well. And once the wound starts to heal, then on the 12th day, the patient underwent a fixation of the pelvis and the left forearm, which was clean. And if there is a need, we would again go in and do a re-debridement of whichever open wound is required. So antibiotic is never a substitute for a debridement. That is very, very important.
We will cover these points in the next cases, but let us see. Anything, Raju sir, you want to contribute? Your sound is not muted.
Hi, can you hear me now?
Yeah.
Yeah. Just a little query. I mean, the plastic surgeon put a flap in. So obviously at that point of time, the wound, if it looked very good, why didn't you just go ahead and nail the tibia at the same time? Tibia and femur. Anything?
So the
I know, but just asking.
Yeah, so the femur wound was taking a little time to heal, and we had a joint spanning fixator on the limb bone. So we and plus the patient had 3 open injuries. So we just wanted to play it safe. Debrided the wound, got a plastic reconstruction. Then the fractures had a good reduction. Waited for the femur to heal up better. Did a debridement at the same sitting for the femur, and once stabilized, then we tried the pelvis and the upper limb, and then the femur, and then once the tibial flap was the flap on the right leg was about a month, 6 weeks down the line. Then we debrided it and did a final reconstruction of the tibia.
Just a query on that. If you put an X-fix more than 2 weeks, is there slightly more chance of infection persisting?
Yes, yes, definitely. There are situations when the X-fix actually, becomes a problem, and especially if there are X-fixes which are stabilizing the femur and the tibia in multiplanar directions. So sometimes, they tend to put the pins into torsional stresses and cause loosening and secondary infections. Yes, definitely that's an issue. But here we wanted our major wounds over the fractures to heal enough for before going and doing definitive fixations.
Good job.
Nitin,
Proceed for any input, sir?
Nitin, this is good for, look, we need to, what is the message for the person who's having a solitary hospital? This is an institutional case only, or if a person in the periphery of India has got
We will discuss those cases in coming sessions. We have 7-8 cases lined up. We'll discuss those issues, sir. We'll proceed to the second case. And it is Dr. Sunil's case. Sir, can you proceed with the case?
Okay. Now this is a 65-year-old came to the open wound with a sharp femur with a massive injury to the soft tissue. So bone loss is almost a grade 3 injury, not neurovascular. So this is the wound he landed up after, say, I don't remember, but maybe 24, 26 hours later, because he was not good condition to have. So this was the soft tissue injury, massive tear to the vastus lateralis and other all tendons. You can see it there.
So the question opens to all panelists. What would they do first in this such type of wound on patient comes to their casualty? What do they do first? What is their approach to this such type of patients?
So Nitin, you have to pick on every panelist and ask them pinpointedly.
Raju Rai Chaudhary, sir. Please. Sir, unmute yourself.
Mute kill.
Yeah. Once the patient is totally stabilized, that is hemodynamically, I would take it at a very opportune, elective, first thing in the morning sort of a case, not the end of the list, not the middle of the night. I assume there is no neurovascular deficit.
No.
In such a situation, I would explore the wound. I would debride it thoroughly. If I can get an extremely clean wound at the end of my debridement, I would do a primary fixation with the nail. I need to see the x-rays.
Yeah. Any other panelists who can share some lights in respect to antibiotics, tetanus toxide, and something like
Skin loss.
Can I offer an opinion?
Yeah. Yes, Abhay.
Yeah, so the minute I see this kind of an injury, the first thought that comes to my mind is 6 hours, 12 hours down the line, slightly dirty looking vastus lateralis coming out torn, tattered, and bruised. Then my first thought was that the debridement of this wound would be a very, very important thing. I'm probably dealing with a distal end femur with an intra-articular extension, in which case I would definitely at the same time want to stabilize the intra-articular extension, extend the wound like a surgical incision would, do a thorough debridement, do a stabilization of the intra-articular extension if need be, and then put an external fixator and wait for the wound to heal. And then go in for a definitive fixation depending upon the type of wound, the geometry of the fracture, and whatever else the patient has.
My contention is what type of antibiotics you can give. You can give instant IV antibiotic, or some you will wait for some time, or then you will start some antibiotic prophylaxis for this patient.
Yeah, so we take him up for a debridement, and the patient gets a broad spectrum coverage along with the cover, which is Metrogel. And then because you don't have time to actually send a culture, wait for 48 hours. But if you've done a good debridement, you can actually, in certain situations, if the wound is not too bad enough, you can wait for 28 to 48 hours and then send a culture and start them on broad spectrum and change into whatever culture is coming.
Amit, you wanted to say something?
Sushrut, I think over here in such situations, we all know, you, me, we have been treating with proper debridement. Debridement is the key to all these injuries.
Absolutely.
And debridement and local antibiotic delivery is very important in these cases if you are doing a primary fixation or whatever you are doing. A local antibiotic delivery is the most important.
Yeah,
that is what I feel.
I agree. I see Dr. Yogesh Salfai peeping in there. Welcome, Yogesh. Tell me what you will do in Chandrapur. This is come 24 hours later from, let's say, very remote forest area of Gadchiroli.
Right.
24 hours. This wood. What will you do?
Am I audible?
Yeah.
Yes?
Yes.
Okay. If such a situation, patient comes to me, I will agree with what Dr. Rajira has suggested. 24 or 48 hours, get him in the OT with all the proper precautions, sterility, debride it. debridement is one of the most essential parts, because any amount of higher antibiotic is not going to replace a thorough debridement. That's what is my feeling. You have to get a photograph of the patient, of the wound, as well as of the patient, because many of the times these are all medical legal patients who come up with such ghastly injuries, and it is always safer to be on our side to have a photograph, which has been rightly mentioned by Sunil. A thorough debridement, get an X-ray done, as much as possible, just remove all the dead tissue, try to make the wound as clean as possible, so that the next stage of the therapy or the treatment can be planned.
Didi, I want to pull you in here at this point. What's the protocol of such late presenting wounds in Ganga? What do you do?
So more the time elapsed, say for example, within 12 hours is okay. Beyond that, if they're coming late, debridement is almost always the key. Once you completely debride it, because it is coming very late, it will not be going in for a straightaway definitive fixation on that day. We will wait for it and then do an external fixation, have a relook again, and then do for the definitive management. So because the colonization of the bacteria is the one that takes place probably as the time elapses. So if they are coming very quickly within 6 hours and all, you do the debridement, definitive fixation can be done very easily. Whereas moment the time elapses, probably say 12 to 24 hours is a gray area, but beyond 24 hours, the colonization starts. So that is why you will have to be very
Your
careful.
cutoff point is first 12 hours, 12 to 24, and beyond 24.
No, not necessarily like that. We don't divide like that. Say, for example, somebody like he has come 24 hours later. So my idea would be to debride extremely very well. And then once it is debrided, all the articular segments, if it is there, we'll have to do the articular fixation on the same day of debridement. And then the remaining fixation will be done as a definitive fixation at later date.
I love to do debridement in my own hands, like a senior level.
Yeah.
Because the debridement is the crucial part, as Amit has suggested.
The debridement here in our center is always done by the plastic surgeon, because we are always together here, and then the plastic surgeons, loop, magnification, and tourniquet is the two things that is necessary. And then with the plastic surgeon under loop, when you debride it, you get a very good debridement. So.
Okay. Nitin, you want to go ahead and we'll talk more on debridement later?
I just want to add one point to this. Yeah. After you debride this, it's necessary that you take a primary culture in this area, deep culture, especially if it is 24, 48 hours old, because this is a possibility of bacteria seeding and growing over here. So you get an antibiotic sensitivity. It is helpful in the long run.
Always the post-debridement cultures are good. Whereas post-debridement cultures, you will not get the culture report as something growing into it often, but occasionally you will get it, especially in those which have come late to you. So that is why it has been proven that culture are of no use unless and until it is like suspected sepsis or in a late arrival wounds. You will have to definitely do a post-debridement cultures.
So one point I want to emphasize that whenever you see the patient, your casualty, first thing you should do it, you should give a IV antibiotic, broad spectrum IV antibiotic, get a photograph of him, evaluate this patient clearly, get a plastic surgeon on your board, show him the wound, show him the X-ray, and then you plan for the treatment. So that is the first thing you should do in this type of patient. Now, Sunil sir, can you carry this patient? This is the X-ray.
Initially in the night only we tried to debride this, because he came in the evening.
So can I stop you, Sunil, there?
Yeah.
If this patient comes midnight, do you personally go, or you schedule this patient 6 o'clock in the morning? And you do?
6 o'clock in the morning, but I don't go in the night anyway now.
Yeah.
So because my team is there, they are quite senior lecturers are there, so there is no problem. So we can just do it initially, because we are really worried about the patient, the get contamination like dust, even in some sort of shit inside. Sometimes there's a bangle pieces, rocks, everything is there. So we need to debride these poor guys, especially this elderly, he is more than 65 years, so he tend to get a lot of infection. So as soon as it comes, we can just give a thorough wash, and then once he's investigated properly for anesthesia and everything, then we can stabilize later on. So it may take 1 or 2 days, 3 days maybe, but with what we plan here is we use routinely a boiled water initially. So saline and lift irrigated wax, everything is later. That comes later. But initially, you have to go into the as a superficial debridement, rather without anesthesia also, if it's possible. But now the legal problems and anesthesia, all these are things are coming in now in very seriously. So the video consenting and all that stuff comes now. But this is an old case. So now it comes little delayed because we have to get the video consent of each and every patient, especially in trauma.
Every patient you take video consent?
Every trauma patient, whenever is getting operated, I get a video consent. I take it, guys. This is very important. You appoint one person and take a video consent while explaining the patient.
So let's focus on this patient.
To take a video patient.
This patient, you will not fix anything in the intra-articular component, as Abhay pointed out. This has an intra-articular component. So
yes, it is. Now this is, of course, this would have been CT scan, everything should have been done, but at this stage, I didn't do it. Yeah. But it is necessary to do all the CT scan and all.
No, Nitin, wait, let's go back. I want to go back on let's stay here.
Yeah. So you can see further, we have reconstructed the intra-articular, which is not that bad. Only 2 fragments, 2 condyles are separated. Only there is no any much hofas or something like that. So we give them a debridement, and then in further X-rays you can see it that the temporarily two cancerous lax screws have been used. You can go ahead, Nitin. What is this? This is not my. This is not mine.
No, this is yours.
Yeah. Now this is my external fixator, and if you see, there is a joint. The 2-3 lax screws have been put to get a temporary fixation of the joint, and is extremely good, anatomically almost reduced. And meanwhile, temporary external fixator was as usual taken. And after that, we are many using in 1996. We are using a Vancouver nail antibiotic coated antibiotic external and rod. We stabilize this. Then so many people were asking me, why did you remove the external fixator? That is a very good question. What wanted to ask the same question to Abhay, while he immediately changed it to internal fixation. Our philosophy is I always remove external fixator. I'll put a splint for 8-10 days, let the pin track heal, and then you go for nailing or plating, whatever you want to do it. Because our patients don't take care of the wound, whatever, because these patients are not going to stay throughout. So I always send them back to home, let them dress, come back after 10, 12 days, 15 days. And then these guys, they won't take proper wound care as you want. Yes, Abhay, you wanted to ask something?
Small query. I mean, that is one point is that the intramedullary strut to guide reduction is a beautiful thing, and even we do it if we can, because it does help to keep your fragments along the soft tissue envelope. But just thinking that did this patient have a bone loss as well? I mean, there is a huge.
There is a bone loss, yes.
So did he lose bone on the road at the time of an accident? Because these fragments don't seem to be adding up to the jigsaw puzzle. I think this patient did have some bone loss at the time.
There is a bone loss, but he didn't bring it. In fact, myself and DD have commonly published a paper of bone loss treated and reinserted back. Remember, DD? I hope so. You remember.
Yes.
Let me ask panel wise. So today, DD, would you do fixator or a definitive fixation if the contamination is being controlled completely by your initial debridement? So what's your take on external fixator?
No, in this patient, because I said no, like, because 24 hours later, if they come, initially, we always use external fixator only,
Okay.
apart from this articular reconstruction, which will be done on day 1.
Okay.
And at the end of, say, around 3rd or 5th day, we will again have a relook. And if everything is looking all right for me, I would have I will definitely think of a definitive fixation, because
change over between external fixator to intramedullary fixation. Do you give some time period or you straight away do it same day?
no, if it is within this 3 weeks to 4 weeks and all, we can straight away go in and do a fixation. Okay. Whereas if established pin tract infection or redness or something is there, then we definitely need to give a time lapse.
Yeah. So,
do you do external fixator first or a definitive fixation?
So depending upon the kind of external fixation we have used, like we definitely started using these intramedullary struts just to keep this jigsaw puzzle in line. And the fixator we use, we don't want to use too much into the distal fragment where we have done a articular reconstruction. So the fixator we would use is with an intramedullary strut, a titanium rod. We would put 2 pins very proximal into the femur and then a connection onto the tibia.
Okay.
And if that is the case and if the wound is healing well, then we are happy to go in and do it. The other thing is, as a guide, as a general principle, if we anticipate that the quantum of bony reconstruction we have to do, along with the possible use of fibula struts or additional procedures,
sure, we will look at that.
We will not do a definitive fixation on day 1.
All right, Amit.
Sunil, 2 questions, Sunil. The first thing, in this particular fracture, do you feel that that intra-articular portion is much more comminuted? Why was the need for doing a CT scan in that? Because this is not very badly comminuted, this intra-articular distal femur. This is one. The second question is, your external fixator pins in the shaft are quite low. As Abhay said, he specifically said that the pins should be very high enough. And because the pins are low, they will come in the way of your definitive fixation. And what is the level of pin tract infections in these cases?
No, CT scan, this is an old case. So CT scan should have been done. But nowadays we have in-house CT. So each and every trauma patient goes into CT. There's no question about it. The question is unquestioned is the CT is absolutely mandatory. There is no doubt about it. So clear. So second thing is, this is a definitive treatment is planned for. Actually, we wanted to do a Elizar fixator. You plan for the bone transport because if the bone loss is there. But eventually, I'll show you then why there was a lot of infection. So prevention of that infection is we put an antibiotic coated rod. This we feel is a very successful in many of our cases like this. So eventually, if you then put a nail, that bone started throwing off. This is nothing to do with this. The bone started throwing off after stabilization with the nail, and it is completely solidly united. So we put a bone graft little bit, and then covered that skin graft. And so everything is covered up. If you see, the bone is completely solidly united. We removed the implant because it was some sort of infection, and he has got a good cover and reasonably good function.
So an antigrade nail in this case?
Yeah.
Antigrade nail was the one which you put here?
Yeah, always do now. I do never do a retrograde nail. I'm not your
now
fan.
it is fine because the antigrade nail now has an AP locking in the distal fragment.
Now it was, I think it is 2008 or 9 something. I don't know which year, I don't know. So
Sunil, question to you.
We can put a retrograde nail which has got a multiple level fixations. Now like a Zimmer design you can have. Yes, Rajiv, you wanted to say something?
Just want to ask the whole panel, does any of your plan change if there are significant comorbidities like diabetes? I get a huge lot of people with diabetes.
Of course.
Does anybody's think plan change?
Yeah, absolutely. So if there is any comorbidities, then I would walk the way Didi is telling, that external fixator and wait till he comes out of that comorbidity. But now my rate or incidence of putting external fixator has dramatically gone down. I would prefer internal fixation and a definitive fixation, even if the patient comes a little later and I'm confident about the type and aggressiveness of my debridement. If the wound is looking clean, then I would prefer, Sunil, to go for an internal fixation, because your soft tissue heals faster, your bone heals faster if there is a definitive internal fixation in place. Do you agree? Do you want to say something on this?
No, it is absolutely stable.
You are
very
definitely
stable.
correct. You are definitely right, because stability is the one that is very important.
Yeah.
When stability is given, infection is almost very little compared to instability. But however, what takes precedence is the nature of the injury and then the amount of comminution. All those things put together, you need to take the call. In this fracture, because of the comminution and then the amount of injury of the soft tissue, you always run the risk of a future infection or something, some of the problems that you could get. So it is preferable to take the safer route, I suppose.
I agree.
Okay. Before we close, I think the very important is to take a video consent, guys. This is very important.
Yeah.
Medical legally, you must take a video consent. How many people are doing it, I don't know, but you must take. That's my
I want to ask Sheru, Dr. Mahendra Kale, if he agrees on this. I'm not able to see him. Anil Masan, Dr. Anil Masan, any views on this?
There are various ways to treat this fracture ultimately. It could be either with a retrograde nail or an antegrade nail, by Elisa Rao, masculate technique. There are a lot of ways to finally treat this fracture. But I think the initial steps should be, in first 24 hours, we have to do a thorough debridement. Second debridement after 24 hours. I would still prefer a fixator, keeping the pins as far away from the fracture as possible. And within 3 or 4 days, aim towards complete skin cover. And by 10 to 12th day, achieve final fixation.
Nitin, are we going to discuss debridement more in next case, or?
Yeah. In next case, sir, we'll be discussing debridement more.
Let's go ahead then.
So we proceed for the Deen Dayalan's case. This is our initial pictures. Sir, can you take this case?
Yeah, I'll take. So this is the fracture that has come in. And you don't keep, you already clicked the other ones. I wanted to ask what will be the...
Nitin, don't push. Let the panelists tell you next, then only you push next.
See, when this patient comes to you like this, then would anyone will think that there is a large contamination?
Obviously.
Yeah. Already you have seen it, so
no.
Raju.
Such an open injury, you do expect contamination. Though on the overall look, you feel that wound is clean. But if you have a closer inspection, especially
because all of you are faculties, you will understand. Somebody delegates may not know. What I wanted to tell you is, when there is a big gash like this, or when it is like blown out like this, because of the suction effect, there will be a lot of contaminants that have gone inside. Next, see, you can see that entire mud particles are into the planes, into the deeper compartments. The moment you lift the skin, you may not see it, but underneath you will see this. This is one of the important things you need to look at. So one aspect is deeper contamination, and also the medullary contamination. So suction effect also will be into the medulla. So a lot of contaminants will go into the medullary cavity also. And then the one area that will have a more of a medullary contamination is the proximal fragment. Because when they fall down, once it is broken, it is the proximal fragment that will go and hitch against the floor, because it is still in continuity with the body, and that is what is going to go and strike the ground. So what happens is, lot of mud particles will enter the proximal medullary cavity. So we need to clean those aspects. So this picture, I got it purely to tell that it is the deeper planes that you need to be extremely cautious, and then the proximal medullary cavity that you need to look in, and then you need to clean entire area, and you have to dissect it. It is the dissection that is the primary role. You have to layer by layer, you have to clean it and then get the picture like what we have got it here. So that is what is the debridement. But now I want to ask panelists, like, how many of you believe in the knife? How many of you believe in the saline? How many of you will believe in jet lavage?
Raju sir.
I'm a knife guy. I generally debride physically, and steelies and a knife is very important. Of course, you need to wash it out at the end of your debridement, and then have a relook again initially, after your wash also, and then if necessary again debride. So it's a process which goes hand in hand with your washing.
Yes, Raju sir.
Didi,
yes.
One good thing this picture shows is the amount of degloving. So your zone of injury is much more than what you really see. So that's one thing. I think probably the pulse lavage is virtually out now. So I do irrigation suction system, and I use saline, or these days we also use a simple saline is good enough. I think probably saline is my choice.
Yes.
Any other view of panelists?
Any other view? We'll go ahead.
Yeah. So can I just add? So when we talk debridement, I think one of the important things that we understand is that when we say debridement, it has to be a debridement under anesthesia.
Yeah.
So just a wound wash has absolutely no role, because with the patient with such severe injury, we may not be able to do justice to the wash or the debridement. So it has to be a debridement under anesthesia, and my friends are my knife, my debridement, as well as the jet lavage. So we use a combination of all three. I guess everybody uses that.
Yeah, I think, Abhay, in addition to anesthesia, very good light system, using loops, because what you can't see, you can't debride.
Absolutely.
So, I mean, loops are mandatory. Tourniquet is absolutely essential. So I think there are a lot of things that go with it.
So these are very important. Tourniquet, loop, and then the knife. You have to every layer of the wound must be debrided.
Yes.
Most important is the patience, I suppose.
Sorry?
Sure.
And the most importance is the patience of cleaning up everything.
Yeah.
What is your view on the pulse lavage or the jet lavage? Dr. Chaudhary said it's almost gone, but what do you feel, sir?
No, the idea was like earlier when they used to have a jet lavage, they used to say it will, but problem is that it can also push the contaminants into the deeper compartment. So that is why it came in, and then they went on to have a low pressure pulse lavage. And then even after that, there was like contaminants was never able to be removed, which is the knife that removes it completely. If you all read the Marco Godina's original book, you will understand that the debridement, the only way to do is every layer you must use the knife and then completely remove contaminant as a one layer. Then you get a clean zone. So clean contaminated wound you will get.
Okay.
Can I add something?
But what fluids do you use, Didi?
So I'll come to that also. Like fluid wise, saline we can use, but what we also use is autoclaved water.
Yes.
Regular water, but we keep it autoclaved and then keep it in the bottles. It is all kept into the bottle, and then once we open the cap and then use it after the debridement. So we can use copious amount of water at the end of the debridement. There is no problem with that. So
all those use any soap solutions, soap,
caustic solutions, soaps, and lot of people also said betadine, but betadine kills the tissues, so we don't use all those things. No soap also. We just use water, autoclaved water.
Betadine is out.
Sorry?
Hydrogen peroxide and betadine is out.
Yeah, it is out because now we should not use, because it can damage the tissues.
So this patient was fixed with an external fixator, and this was final X-ray, and this was final wound.
So once the debridement is very well done, then because it's an extensive wound, see sometimes if it is a smaller wound or anything like that, then you can also think, okay, let me do an interlock nailing, because it is a stable type of fracture. You can also do a nailing and then get away. But often when there is a wide extensive wound like this, you might think of having another debridement phase. So it is better to do an external fixator, keep a safety protocols, and then once that is done, of course, later on you can do next slide. After some time, you can either do a plate fixation or nailing later on, and then you can get better results. So debridement wise, for us to have a very good outcome, it is the debridement. The only way we can get the debridement is by involving the plastic surgeons on day one. So that is our take. Because if we always pin them. Suppose if it is an infection that settles in, we will always tell you have not debrided very well. So that is why they will take extra caution, and also because it insults their pride, they will do it very well. And of course, as we become experienced, we can also do the same amount of debridement as we become experienced. So
Dr. Deen Dayalans has presented an AO trauma webinar on webcast on infection, this compound fracture as well as nailing of an tibia in an compound fracture setting. So there is a link on the screen. You can go onto this screen link and you can see how the nailing is being done and how the debridement should be carried out in a systematic way, layer by layer. It is around 1 hour and half, 90 minutes video is there. You can look at it for the delegates and you will understand how to do an excellent and good debridement. So we proceed to the next case.
Can I just?
We will address some issues in this case also, debridement and something like.
Yes, Amit is want to ask something. Rajiv?
Yeah, Rajiv sir?
Yeah, Didi, can I ask?
Yeah.
Can I ask? Was there can you just show me the last slide, that plating which you have done? Can we discuss the fracture case? Yeah, the plating. Yeah. What was the specific need for doing a plating in this case?
No, that's why I didn't want to say why plating or why nailing, but you can do any of these things. But see, like it is an extensive wound. It was an extensive wound in the beginning. We have seen it, and also like I didn't want to go in and then start doing a nailing and then play a bone grafting to expose everywhere. So I thought if I have to do a bone graft in this patient, anyway I expose for the bone graft. So let me just put a plate for that. That's the idea in that. So otherwise nothing else.
Hey, Raju sir, you want to ask something?
Yeah, a wonderful message. I think that you can do any sort of fixation, but the debridement is so important. One little problem I've had, DD, is, when you look at the proximal fragment, dirt fragments get into the bone, the spikes of bone. So I want to do is nibble that bit of bone off. I remove a bit of bone off at the proximal fragment because it's impossible, even with anything, to get those bits of particle that go into the bone.
Sometimes you can nibble it off, but many times if you take a 15-blade knife and slowly scratch on the edges of the bone, you can take off those particles that are imprinted onto it. So we can definitely do that way.
So we'll proceed to the second case.
Just to add to the thing, this use of fluids and pressure, look up flow trial 1, trial 2. They'll answer all your questions.
Yes.
FLOW, just Google FLOW.
Yeah, I would suggest one more option. For this mud inside the medullary canal, you can use a lot of fluid going in and suction to bring out everything. And you can use a needle, just like Didi suggested the 15 number knife. You can use a needle and you can scrape off slowly and slowly all the dust that has got inside.
Your video is incorporated in this, sir. We will show it.
Sure.
Thank you, sir. We'll proceed for next case. Didi, sir,
Yes.
this is your case.
Yeah. Okay, next. So next slide. So this is a 24-year-old male. See, both sides it is similar type of an injury. He came one day later because he was stabilized in the periphery, and then they have put an external fixator, and then they have sent. So suppose if they come with an external fixator, say for example, I am sitting next to Rajiv, and then say Rajiv is only 1 kilometer away, and if he says, Rajiv, I am going on leave, please do it, means one of your friend takes over like this after one day, what will you do? Rajiv, what will you do like that? Suppose your friend sends you that he has said he has debrided it and sent it to you, what will you do?
Which Rajiv? Two Rajivs.
Yes, yourself.
Yeah, any Rajiv, Calcutta Rajiv.
Calcutta Rajiv. I would still take the patient back to OT and relook debridement. I just cannot
always that is important, because we should not leave it thinking that somebody has done the debridement. even if it is close friend, you must take it and then do a debridement again, because you need to have a look and you need to decide it based on what you see at the debridement. Any other thoughts?
Yes, one opinion, even in the last case and even in this one, like you said, it's a very good practice to have the plastic surgeons on board on this on day one. So even if we are going to be debriding it, we want our plastic surgeons to have a look in terms of what they would like to do in terms of a plastic reconstruction or a flap.
Yeah.
So our principal fixation, the external fixation, will keep in mind the kind of flap the plastic surgeon is envisaging to do, so that we don't spoil the perforator areas in this region, because fasciocutaneous flaps are a very, very good thing to do in the lower limb reconstruction, and we don't want our pins to bugger up the pedicle which is coming through the fixator. So we do take in on almost on all cases a plastic surgery opinion in terms of what they would like to do in terms of a flap or a reconstruction.
Yeah, Didi, nowadays we have started doing what is called IVAC, irrigation VAC. Okay. So the VAC is very important now for such kind of those who have blessed like Didi have a plastic surgeon along with the entire team. But we have a plastic surgeon, but we need to believe in ourselves also. So first thing is we have to put a VAC on this. So irrigation VAC serves much better. Once the wound is clean, then you can hand over it to the plastic surgeons, because they don't allow you to movement. And I would also do a realignment of this fragment reduction. The external fixator can be continued till the VAC, and when the cover is there, then you can plan for the further definitive line of treatment.
So in fact, Sunil, if I can barge in there, I go the other way. So two things which I want to suggest. There is no one debridement. So the first debridement is very, very aggressive debridement. Second debridement is aggressive. So it can be a sequence of debridement sessions till the time you are not happy. I prefer to, of course, use irrigation VAC, but before I hand it over to plastic surgeon colleague for a definitive management, I would want to convert that X-fix into some kind of internal fixation and then give it to him completely. Because number one, external fixator will come in his way. Number two, you never know when he will hand it over to you, and patient will land up with a lot of morbidity. So these days, once I'm comfortable with the wound status, definitive internal fixation, and then give it to plastic surgeon colleague. In fact, he can come in between and continue with the debridement and assist you during debridement. So he comes much earlier in the role.
So one small thought, if you permit.
Sure.
Looking at the reduction of this particular injury, we also probably factor in if we can restore the length, rotation, and alignment to the best possible situation that we can, because that ultimately has a bearing on the kind of soft tissue envelope you have ready for healing and later on repair. So sure. If I feel that if the patient has come with a fixator in situ, and I feel that along with the debridement, I need to do a fixator readjustment, I will not hesitate to go in and do it again. So get the best possible length, rotation, and alignment.
Okay, Adil Masan, you want to ask something?
Yeah, so I'd just like to add, DD sir said when such a patient is done, debridement is being done and referred to you, I would tell that surgeon, please don't close the wound, because what they generally do is they debride, close the wound and send, and that causes more skin necrosis, sometimes even compartment syndrome.
Sure. Amit, you want to say something?
What I feel is Sunil said that he would continue with this fixator, but I don't believe this is not a fixator. I would go down, remove everything, whatever the fixator, because it's impossible to do any sort of definitive fixation in this case. If such a lot of so many pins are there, they will all be a source of infection in this case. So what I feel is
I didn't say, Amit, I didn't say continue the same fixator. I said realign everything, reduce it, and then put a fixator.
All right. Okay. Rajiv Chatterjee.
Can I just since we are talking about fixator in this case, a lesson to be learned. See, the pins are in the zone of your fixation later on. To be avoided. And
Rajiv, let me stop you there. I'm sure Didi has shown this case. This is a very old case that he is trying to demonstrate something to us. So
Let us
No, here I wanted to tell that if you want to debride this wound, it is always better to remove the external fixator, because if you remove external fixator only, you can see all the fragments, everything. You can open it and then see the deeper tissues. So then you will have to do that. So that is
I'm
why
sure
I put
Didi
in
won't
this case.
do this today. So I know this is only for demonstration. Didi, please
Yeah.
go ahead. Please go
Yeah,
ahead.
so that's what we did. And then the same day after debridement, we put both bilaterally, we put the limb reconstruction system. And the next slide, next slide, next slide. Yeah, see, transport has been started. Next slide. And this is the final, next slide. So it goes on to heal well at the end of the scenario, and then he gets into a good sort of outcome. All this is possible only because of debridement. That's what I want to tell you here, because the whole point of bringing this is to show that debridement plays the biggest role. And when you have a good debridement, you can also combine the procedures. You can also do a limb reconstruction system, flap, on the same day of our arrival, and then complete the procedure. You can transport underneath the flap and then get the outcome as that of a closed type of injury. The time duration, everything can be reduced.
Okay. So can you throw some light on Ganga trauma score?
Yeah, Ganga Hospital score, like, I think all of you are aware of it, I suppose, because if I have to tell you, then I need to tell the whole presentation as such. But only thing is, it is based on the components, because we are, see, like if you take Gustilo classification, it is purely based on the size of the wound. Whereas Ganga Hospital score is like, it is based on the components of the injury, like it involves the skin, it involves the bone, it involves the functional tissue, and also the comorbid conditions. All of them are taken into account. Incremental score is given to each of the components, and then it is grouped and then given. So if the score is less than 9, you can also go and do all the primary care itself. That is total care you can give. If it is more than 9, it is better to do a staged reconstruction. So that is to summarize everything. So I don't, if I have to do, then I'll have to speak for longer time.
So when do you do in the such ghastly injuries, when do you decide about amputations?
See, like if the score, if the score is less than 14, up to 14, you can salvage it. 17 compulsorily amputate. 15 and 16 is like a gray zone. So depending upon the skill levels and then the technical availability and then all the infrastructure possibilities, then we said 15 and 16, you can think of either going in for a salvage depending upon your capabilities. But what we have got is based on the 109 cases that we analyze in that series. 14, up to 14, you can safely salvage. 17, you have to amputate. 15 and 16 are the gray areas.
So on the day when you amputate the patient, or give some time to think on?
No, if it is 17, we amputate. 17, if we amputate, the remaining we think of salvage.
Okay.
So can I ask a question?
Yeah.
Yes.
The app, why is it down? The app is no longer available.
Is it?
Yeah, I tried it because I had it on. It went off. Then I, from Ganga Hospital, somebody called me saying that it'll be updated, it'll be on, but I have not got it. It has saved.
You told me in a TraumaCon, and then we again updated it. Okay, now I will find out again. So.
It has saved me. Believe me, it has saved me.
Yeah, I'll find.
I've shown the patient the calculation, and patient has an amputation based on that. It really saves.
Thank you.
Okay. Thank you for that.
Yeah, now with Ganga Hospital score, one of the big advantages is that all the postgraduates have definitely to read, because it is coming as a question paper. So in all this examination, it is one of the questions. So everybody is reading it. So
it's a fantastic thing. Really saves me. Really saves me. Thank you.
Thank you.
So we proceed to the Dr. Rajiv Chatterjee's case.
Yep.
This is the case. These are the.
This is very small area. So just give little history. This gentleman, 28-year-old gentleman, had a bit of an argument with a truck tire coming back at about 9:30, 10 at night from work. So you see that is the thigh, right thigh is degloved from top to bottom, and there's two small wounds at the bottom of the tibia. So literally complete degloving. There's a bottom wound around the knee, and this is from the top. Next slide. This is how it came to us. What we have in our casualty is the back, please. Yeah, so what my casualty in ER, what is done is just as the patient is being resuscitated, a quick, just thorough wash is given, just padded and sent to OT. Then this was about what 11:30, 12 at night. I came up. Unfortunately, I come up with my plastic surgeon for all these open wounds, whatever time of the night. I don't leave them for next morning with these sort of wounds. And the plastic surgeon and me both do it together. He had a simplistic fracture of the femur, distal 1/3. This is, you see the wound before and the wound after. This after the first debridement. The plastic surgeon, I did first stage, plastic surgeon moved in. And you see the amount of skin that's been removed. We started with just below the knee. After he finished, he took off more than half the calf skin. It's completely red, normal, living muscle that looks at you. He had also ended up having a lateral side open wound. So basically, we put an X-Fix on and kept it on and took the patient back to OT after 48 hours. Okay, stop there. So how many of you in the panel would like to go ahead and fix it at this point of time? This 48 hours. Would you carry on with X-Fix and repeated debridement or do something else?
I think
with plastic surgeon.
Yeah, with such an extensive contaminated wound, I would not think of fixation. I would have a second look at 48 to 72 hours, re-debride if need be, continue with the external fixator. Maybe I would put in a vac after this. It will require a few days before some more dead muscle and everything really shows its true color.
Yes, Harshad, you have a different opinion about it?
I have a question for Rajiv.
Yep.
Rajiv, is this the original wound or the picture that you showed is after the debridement? So that's it's a bilateral injury.
No, it's right, only right side.
Right.
Side, so original wound was the first one.
The picture post debridement that you showed, the debridement wound is going right up to beyond the greater trochanter. Is that not?
No. Go back.
He's going ahead.
So just stops here. It's not beyond the this. It stops much distal to the greater trochanter. It's because of the drapes. It's because of the drapes. So greater trochanter was empty. There was no wound there. So actually,
and how happy were you after finishing the debridement? Were you comfortable, or you thought you had left behind something? Or
I mean, I had a plastic surgeon with me. We were very happy, and this is 48 hours post debridement. Just open the wound. I haven't even given it a wash. Just open the wound.
Okay. So I would not be brave enough to do an internal fixation here at this stage, especially after 48 hours. The fracture, if you see X-ray wise, it's more or less transverse. It's not a very badly displaced or bone loss type of a fracture. Here, I would be more comfortable in using an LRS or some kind of device where I can do an active compression at the fracture site by an external means. At the same time, do something to cover the wound. May it be vac, may it be skin grafting when the wound improves. So definitely, I would be a little reluctant to doing internal fixation.
So we've started thinking a little differently on this. As Sushrut pointed out, the experience has been that external fixators necessarily may not be the greatest thing, and what we have been experiencing is that they sometimes act as perpetuators of infection and non-healing of wounds. So if in the first day, like the picture that you showed, if we are very comfortable with the kind of debridement we did, and we do not have to do a very significantly major bony reconstruction, I would actually go in and do a fixation on day one. And then look for aggressive debridement, follow-up debridements, and a wound cover.
Absolutely, that was my thought process. Unfortunately, the first day was at night, so obviously didn't have the implant. This 48 hours, opened the wound, looked as red as, I haven't even given it a wash. Look at it. Normally you see a green slime on it. There's no green slime on it. So we have gone beyond the area. So I went ahead, removed, and take your point very well. An X-Fix is an unstable assembly. Instability is one of the causes for propagation of infection. So went ahead, nailed it, put a 2FN type of nail. I do agree, I've left a bit of a gap there, but I just did it quick in, quick out. patient lateral on the table, gave it on to the plastic surgeon, who rotated. His main job was to close the fracture site. He rotated the muscle, closed the fracture site, so there was no fracture site exposed outside, and put skin graft on top. The point here is, if the plastic surgeon has to be good enough, and you have to be good enough to make sure that no exposed bone remains outside.
So can I add to that, please?
Yep.
So our thought process on the table with such injuries is that if I'm able to, if I have a very good, reasonably healthy looking muscle cover, then I would go in and do a reconstruction. Even if I have to do a small myoplasty for a defect and still have a decent muscle cover, would still go in and do a reconstruction. But if the quality of muscle is looking confused or damaged, then obviously I would wait it out.
Point taken. We proceed. These are the advantage of definitive fixation.
Sunil, you want to say definitive fixation? Sunil Kulkarni?
Yeah.
You wanted to say something?
No, you see, our protocol is not directive because we have get a lot of more bad contamination than this. So we are using antibiotic coated nail for all these compound fractures, especially for diaphyseal fractures. We do it in a stage procedure. We stabilize with the external fixator. We put a vac, we put an antibiotic coated rod, and then stabilize and give some good after. Once everything is healed up, put a cover and then lock it, exchange nailing. Believe me, this gives excellent result. We have a lot of things that we have
many ways to skin a cat, but better stability, better soft tissue healing, faster fracture healing. So that's the way to go. Yes, Amit.
Sunil, if you're putting an external fixator first before the antibiotic rod, what is the use of an external fixator? I think primary you can do an antibiotic rod.
Nail, see, that's what the nail. I'm not using an interlocking nail.
Yeah, exactly.
The interlocking nail. What will give the rotational stability? It is a small nail inside.
So you do an external fixator along with an antibiotic nail.
Yes. And keep in mind that the pin should not touch the antibiotic rod inside. So you have to put the fixator in such a way that you don't pass your pins and it should not touch inside.
Okay.
But your antibiotic nail would not be for a rotational stability.
Nothing. It is just to control the infection. It is nothing to do with stability. Many times we are lucky that it has united in that position. So it is good.
So why unnecessarily add an added source of infection and external fixator?
Then how will you give stability?
Rotational.
Sunil, how long do you think that antibiotic nail is actively pouring out antibiotics?
3 weeks.
2 weeks.
2 to 3 weeks maximum.
Correct.
Actually, that is also a myth. We don't know because in TraumaCon, the Italian guy who gave a lecture, within 8 hours the biofilm is formed.
Yeah.
Within 8 hours the biofilm is formed on any implant you put in. So this is all this. So antibiotic coated nail, which really helps to leach out these antibiotics locally, at least for, I would say, 1 week or 2 weeks maximum, so that it will not give you infection and it will allow you to do early whatever the definitive line of treatment.
After that, it's acting like a foreign body inside.
Huh?
After that is I think he replaces it.
No, we have to replace it, of course. After the antibiotics is leached out, we have to remove that nail and do action nailing.
In 3 weeks.
In 2 weeks rather.
I agree with you at that point if you have a very badly infected wound, but the most important point is debridement. If you have to get to a debridement level where nothing is left.
Antibiotic nail is not going to replace your aggressiveness.
Exactly. Nothing. No.
Debridement is the most important.
It is an adjuvant. It is debridement. There is no replacement.
Absolutely. That is the point. You have a good debridement. That is most important.
Yeah.
Nitin, you want to go ahead?
Yeah, but at the same time, there are times that at 48 hours, 72 hours, when you do a second look, you have to do a re-debridement. So it's not necessary that the first time you're happy. It has been many times you're happy, but at the second stage, you see that there is some dead muscle that could be a seed focus for infection later date.
So the answer to that is that second look, if you have dead muscle, do another thorough debridement to living muscle. But
that's right.
Stable fixation. So the cornerstone of success is a very thorough debridement, early stable fixation, early wound cover. These are three cornerstones we have to look at.
The antibiotic coated nail gives you three points. One important is you have to ream it. So inside the debridement of the intramedullary cavity is also automatically done. It gives a good leaching out of the local antibiotics and also gives a little stability. I don't say rotational stability, but at least the axial stability little is going.
It only gives alignment. It will not give any stability.
Don't expect anything. Don't expect any stability from that nail.
Okay. Nitin, do you want to go ahead? Nitin?
Yeah.
Anyway.
So we study something like the principles of soft tissue reconstruction. Like tissue with like tissue bank is an human body limited resources. Consider the side morbidity. Should also consider functional as well as aesthetics aspect. Should consider for movement of joint after tissue transfer. You should always have a backup plan. If a flap is failed, then you should be able to do another thing. So primary closure techniques could be done in this type of open injuries, wound with skin loss after wound without skin loss after debridement. Injury to debridement interval is less than 12 hours. Bleeding wound margins and stable fixation internal or externally. Then you close the wounds. Local flaps can be done as a skeletal if the skeletal stabilization is being done aggressively at the first sitting itself, or patient can be placed for a free flap reconstruction in a staged manner. There is an decreased infection rate if the soft tissue transfer is done in 72 hours or till the 7th day. You can consider this classical reconstruction ladder, starting from healing by secondary intention to the free flap. Consider now this big wound on the shoulder with the fractured clavicle as well as comminuted fractured shoulder, and this was been primarily closed fixation of fracture. So this was the 3rd day picture, and this the picture on my right side is after 3 weeks. You can see that there is a necrosis of the free flap after 3 weeks. So you can't definitely comment on the day 1 whether this flap will survive or skin flap will survive or not. So you should focus on interaction of all these tissue transfer modules like skin graft, full thickness skin graft, tissue expansion, random flap, pattern flap, medical flap, and free flap. We'll go for one case. This is an open grade 2 fractured tibia with bone exposed in a 48-year-old man. So what could be done in this patient? Here nailing was done. It was unreamed nail. So what is the panelist opinion whether the nail should be done as a ream nail or unreamed nail?
Ream nail.
Ream nail.
It's very clear nowadays. Just
thickest nail.
Okay.
So let's close this debate forever. There is nothing like unreamed nail now. Not anymore. Okay. We want to have a snugly fitting nail. So unreamed nail doesn't exist anymore.
As expected, this gone into non-union, and it was again done with a bigger size nail, ream nail, and this was then healed up.
Can I add on this?
Yeah.
The hypertrophic non-union, because there is an anterior posterior hole which is kept vacant. Okay. See that there is a vacant anterior posterior hole which should have been given a very good rotational stability.
So that would have healed the fracture.
Yeah. And now as I have started, because patient can't afford the second surgery, second nail. So I am adding 2 polar screws along with that nail. Just give a simple polar screws. And I think I have done about 5-6 cases. It has all healed. Because what is this giving is a rotational instability.
Yeah.
So you prevent that rotational instability, it will unite. That's the principle is that. So don't do it, try it first, do that and then do it.
One quick comment, Nitin. Can you just go back to the original X-ray after the nailing? Yeah. So if you look at the X-ray on the top, the degree of comminution on the tibia is much higher than the fibula. So the fibula apparently is non-comminuted, which would mean that with a nail in situ, if the fibula heals, the tibia will not heal. It will go into an hypertrophic non-union even if the soft tissue heals because of apparent effect. So if you have an open wound and if you're going to do a nail, I would probably not hesitate in doing a small colectomy and then doing the nail.
Okay. Fine. We proceed to the next case.
Allow you take somebody else's case. Don't repeat the case first. Let them finish first. All the time.
Okay, sir. Point taken. So we'll take Rajiv Rai Chaudhary's case.
Yeah.
Sir, all yours. You have unmuted your screen, sir.
Rajiv.
Rajiv. Rajiv Rai Chaudhary, sir, are you there?
He's there, but he's muting.
Please unmute yourself.
I'm there.
Yeah.
So,
Bolo, sir.
I'm unmuted now.
Yeah.
Can you hear me?
Yes, yeah. We are.
Yeah. So this is a 26-year-old male, and he has got a vascular injury as well. Can you go for the next please? Can we go to the next part?
Yeah.
Hello. Can you hear me?
Yes, sir.
That's right. So that is, yeah. So basically, we can see that this is a young chap, neurovascular injury. There is no other injury. Now, initially, a thorough debridement, a simple temporary fixator, vascular repair with some bone shortening was done. Next, please.
I will like to show the debridement video which you have sent to us.
So, can you mute the video so I keep on speaking? Yeah. So this is an irrigation system. It is gravity dependent. Yeah. Keep on. That's right. You would see I use very little knife. I use mainly suction and continuous saline. Even for the muscle, I do my initial debridement with the suction and irrigation only. I have yet to come for the knife. I use a scissor later on. The margin of the wounds, I was taught always use a knife. I don't use a knife. I try to preserve as much margin as possible. And I managed to get a very clean margin at the end. I use the forceps to pick up all the dirt, as you would see here. Somewhere along the line, yeah. And then when coming to the bone and the fascia, again, I'm using the suction and total cleaning, and I use a needle to clean all the dirt that is on top of the bone. The skin also, the abraded skin, etc., I would clean. And that's, if you would see, I've just used sharp dissection of the scissors to debride the dirty part. To quite a large extent, I follow the Ganga system of fixing and then putting in a flap initially. Whenever there is sharp debridement to be done, obviously I get to the vascular surface with scissors. You can see that there is continuous saline that is coming on top. This is under a tourniquet, very good light, lot of time in hand, and always remember that under the tourniquet, what you see is white, is right. It is not avascular. What is red is dead. So if you remember this little sentence, it will help you. We can go to the next slide. So a little bit of shortening, and 8 hours later we had the vessel reconstructed. Always ask your vascular surgeon to also repair the veni communicants, the veins surrounding the vessels, so that later on you don't have too much of post injury edema that many of these vascular people have. Next slide. An initial cover of the vessel was done only using the rotating muscle, and then 10 days later, a free flap with an external fixator, with a Elizaro fixator. Next slide. Unfortunately, there was flap congestion. I think we have to be very vigilant, because the plastic surgeon goes away, and in small setups, etc., we must see the flap ever so frequently. Next slide. So this was re-explored. The flap vascularity retained. Can we go back, please? And then we had flap necrosis. For this case, we should not be disheartened. Next slide. So the flap advancement was done. So that was the final picture. We have lengthened the bone proximally. Next slide, please. Next slide. That's the final X-ray picture at 15 months that you can see. Next slide. Next slide, please. You can see the amount of dorsiflexion of the left side that he's sitting on the right ledge. Yeah, he's the person you can see in the center coming down the steps. Totally independent, has gone back to his job as a supervisor in a construction company where he has to negotiate a lot of steps up and down, and those also under construction. Got married, so that's his wife. Thank you.
Any comments from the panelists?
So there are some important points that I could add here, that whenever you're debridement, initially just keep a simple fixator, keep ankle at 90 degrees. One of the very common things is you don't stabilize the ankle. Later on, you get into equinus deformity, which is very common. You should tag all your nerves, vessel, tendons for later on. Always tell your plastic surgeon if he's taking the vein for arterial grafting, if he's taking a vein graft, then he should not take it from the opposite saphenous vein. He should take it from one proximal to the knee, so that in case later on you want to do a cross leg flap, if he has used the vein, that incision will jeopardize the cross leg flap. So I have now stopped taking. Our plastic surgeon is very blankly. He's told that not to touch the vein on the other saphenous, on the other leg. Cover all the vessels. Now, very important is you have to, you see, the patient knows you. He doesn't know the plastic surgeon. So if there's any problem that occurs, they first come to your consent and inform that this will be multiple surgeries, the cost involved, the time duration required versus an amputation and salvage. These should be, I totally agree with Sunil that recording of these things should be done as a routine. Photographs at all stages should be documented. Documentation is very vital. Next slide. Next slide. Out of the trauma zone, you can work at any time, but in the trauma zone, you must avoid the 5th to the 10th day. Early passive motions should be instituted. Now, the day the patient comes, you should have your master plan till the end, and your backup plan should be made on day 1 itself. Okay, if this problem occurs, this is what I'm going to occur. So you have planned everything in advance. Next slide. Next slide.
So that is final.
Yeah, okay. Thank you.
Small comment.
Any other panelists want to have some discussion on this?
Yeah, one comment. So over a period of time, we've realized that probably if we had to stabilize with an external fixator of some kind and get the plastic surgeon to do a flap of any kind, depending upon the wound. So sometimes using an Elizarov can be a double-edged sword, because it has a multi-planar fixation, and in case sometimes you need to advance the flap or goes into a flap, a necrosis, and you have to do something additionally for the wound, then the frame itself becomes a deterrent towards helping you to do the wound. So even if, like in this particular case, we very beautifully left some space and not put fixation into where the bulk of the flap is, but still if you have to advance the flap, and so sometimes the frame itself can be a deterrent. So probably in certain situations we would still want to use a simple tubular external fixator or an LRS to do the job of fixation for us, the external fixation.
The thing is that, as Dr. Chaudhary has said beautifully, that our dependence on plastic surgeons is a bit too much. And in centers like AIMS or Ganga, it's fine. But in other places, if the plastic surgeons take over and see what happens, they just do their job and then they run away. The thing is that you have to properly monitor your flaps, especially these free flaps. And a question to Dr. Chaudhary.
Yes.
Regarding that, the vascular injury.
Yeah.
Were both the vessels involved, the dorsalis pedis as well as the posterior tibial? Because you did a vascular repair over there.
That's right. We have both the vessels were injured. Initially, the posterior tibial was repaired with the veins. The flap was fixed. The microvascular flap was with the anterior tibial artery. So it was the anterior tibial was not initially repaired. Only the posterior tibial. The flap was sutured with the flap vasculature was sutured with the anterior tibial.
Okay.
Okay. Any other panelists? Yes, DD sir.
No, like on the comment of Chaudhary sir saying that plastic surgeon, the patient does not know the plastic surgeon. Probably that is the problem, I suppose, because if you involve the plastic surgeon on day one and tell the patient that he is the plastic surgeon, then that plastic surgeon will take the responsibility. I think that is where the connection has to be set right.
I totally agree. They are always the patient is and the plastic surgeon have been they are in the loop. The counseling has been done by the plastic surgeon, but when something goes wrong, the patient always comes in and says that you call this plastic surgeon, we don't know him. So directly or indirectly, the barrel of the gun and the bullet comes onto your head.
Okay.
Can I just add to just one little point to this?
Yeah.
Whenever we counsel in a trauma scenario in my hospital, it's always a plastic surgeon and me speaking together. We have this thing that if the patient is in ICU, it's always me and the intensivist speaking together. So you have to always show this face that two of you are working together. It gives a lot of comfort to the patients.
Okay, point taken, sir. Proceed for the next case.
Yeah, Anil wants to ask something.
Yeah. Unmute yourself. Anil sir, unmute yourself.
Okay. Yeah. So my experience is when we are doing distal tibia and foot, there is a lot of post-operative edema. So in order to take care of that, after skin grafting, it is a better idea to put VAC. So the chances of post-operative edema is taken care of very well.
Okay, point taken, sir. We proceed for the Amit's case. Dr. Amit sir, please proceed.
Yeah. This was a 23-year-old young boy, a road traffic accident. Before putting on the next slide, just wait, Nitin. What will you do? X-rays and all these things. Nitin, don't proceed. So what will you do, the panelists over here? Would you offer further treatment or would you wait or would you amputate? Sushrut?
He's not there, bro.
You need a good X-ray.
Okay, Sunil, yeah. Sunil, what is your view?
The first thing is don't jump onto amputation. There is nothing. The amputation you can do anytime.
Yeah, now that I'm presenting, there must be something.
Yeah,
Otherwise,
so you are presented. That means you are not amputated.
yeah, exactly.
My thoughts, if I can share one.
Yeah.
So, right hand dominant, I have had the opportunity to amputate primarily on day one on one or two of my patients, and somewhere down the line I've regretted it, because a lot of these injuries down the line we've realized with a very good debridement they can do extremely well. So on day one probably would wait till such time the injury evolves into a situation where you have to amputate. Probably today I would not do a primary amputation on day one, even with.
And what do you do here in this case?
I would take the patient up for a very thorough debridement. Obviously do X-ray, see what is
all the contamination, all the grease and everything of the road.
Would do a debridement, would do a stabilization with an external fixation frame, and then just debride again if need be, and wait out the healing of the soft tissue with a plastic reconstruction and see how it goes.
This Ganga score around more than 10. Didi, what would you do?
No, upper limb is always preferable to salvage. So whether question of it's a lower limb, you can think of amputate, because there is no very good prosthesis in upper limb. If this acts like a stump, it is always a good. So always better to go in for a good debridement and then get going with reconstructive procedures.
First of all, I would like to tell you that this is not an upper limb, this is a lower limb.
Oh, sorry.
This is the foot. So I go to the next slide, Nitin.
Yeah.
Okay.
This is
so
the lower limb. Yeah. So now given that it is a lower limb, what would you do, Didi?
See, lower limb, see, like we need to look at whether the first ray is good or not. So even then here we go in and then completely
get a good audio and screen.
No, I think first we'll go a good debridement and then have a look. Otherwise, it is very difficult to tell now straight away.
What consent would you take from the patient, Sunil?
Video consent.
What video consent for an amputation?
No. You can take till you can try to save it, but many things you have to remove it in between. You have to be.
Yeah, exactly. If you try to save it as a secondary position. Yeah, as a secondary
so last thing is amputation. So you have to take a video consent, everything. That we will try to save. If it is not possible, we can go amputation in later stage. Don't jump onto the amputation immediately.
Correct.
Explain consent. Explain consent even for on-table decision of amputation.
Correct.
Patients, they come, they always want the limb to be saved.
Obviously.
They are biased that the limb has to be saved.
But you also want to save the limb, isn't it?
Yeah, exactly. You also want to try something, to do something. But then most of the doctors whom I consulted later after treating this, they said it's an amputation case. Anyway, I tried. It was a Sunday. Sunday the patient came. I did not have much staff. I called all my the OT staff and everything, and around 3 hours I was just debrided everything. I just did not. I had the greed because at first metatarsal was very bad. This metatarsal over here was very bad, and even then I put multiple K wires over there and put an external fixator. Next slide. Next slide, Nitin. Yeah. This was the way I debrided it, and then next slide. This was at least looking like something which could be. Yeah, I washed it with pure water, saline, and proper Savlon solution. I did a pulse lavage over here because there was nothing to save. There were all the deep tissues were already gone, and this was the way I debrided it. I put an external fixator. It was very difficult to put a vac over here because of the external fixator. I called the vac person. He did somehow the vac. Next slide, Nitin. Yeah, is the video running? On day 4 or 5, these were the maggots. Next, previous slide. There was maggot infection inside it. This was very bad. Now, at this stage, what? Any opinions? These were the maggots inside.
What about sensation?
The soul sensate.
Sensations was good. The capillary pulsations were good.
The soul is sensate.
Maggots are good.
Yes. Soulless
Maggots means it
sensate.
has not been dressed for the last 2 or 3 days.
Maggots are good and they are
daily dressings, sir.
maggots are good and they are bioscavengers.
Absolutely.
And could use turpentine oils because once they are done with their surgical treatment, you would probably have a good looking wound.
Yeah, correct. Absolutely right, Abhay. Didi, your opinion regarding this, even at this stage, can you still save? I think so. I think you should try to save.
You can still continue to save, provided this first metatarsal bone is continued to be viable. Suppose if this becomes necrotic, probably, see, like, even if the lateral ray is good, if the complete lateral ray is good, if the weight-bearing portion is going to be on the lateral ray, even the medial side, we can completely take it off. Complete ray amputation you can do. Still, the patient will walk very well. So that is what is the key.
Yeah.
So,
Right. So what I did after this was day 4, 5, still went on debriding it, and it was only pure saline dressings. As we told, we don't use betadine nowadays, so it was pure saline dressings. We debrided regularly. Next slide, Nitin.
Yes, sir.
Yeah, this. I removed the external fixator because it was very coming in the way of my dressings, and I was not happy doing dressings with the external fixator. It was quite stable. I put a slab, a simple slab, posterior slab, and did all the dressings. Now the first metatarsal comes in the way. This is I think 3 weeks post-operatively. Now with the first metatarsal over there, bad, necrotic, Didi said if we should excise the first metatarsal. Sunil, what is your opinion?
I thought there is a black skin.
There is no skin over
or
there.
A bone?
No, that is bone. There is no skin over there. The skin has already.
If it is necrotic, then there is no point in keeping it.
Yeah.
You can
But
now
for some
you can do a 3D printing and put it there.
Yeah, correct. Now, next slide.
Whatever is black, including the exposed tendons, I think they have to go because without the tendon sheath, the tendon will also necrose eventually.
Yeah, correct. Now the tendons were not there at all. The only good thing was that it was in the neutral position, and this was it. Granulation tissue was all coming next to it. Next slide, Nitin. Next slide. Yeah, this was around 5 weeks, 5 to 6 weeks. It developed a lot of swelling. I had, there was a big flap from the posterior side. The sole flap was there. So now this sole flap, I just put multiple KOIs from the sole into the calcaneum, into the ankle, through and through, fixing the ankle joint, and made the patient was by now walking with support, that is with a walker. He had developed a lot of infection and swelling over there. I continued with antibiotics and regular debridements. Next slide. Then I went down, and at around, this was the first metatarsal area. I removed the metatarsal. I debrided the whole thing and put simple skin graft. Next slide. Next slide. This was, I think.
Did you do this or your plastic surgeon?
No. Skin grafting, I do myself. I don't believe in the plastic surgeon for skin grafting. Flaps are okay, but sushrut, we have been taught skin graftings very well. We all know skin grafting. So I think we do a better job in skin grafting. And this was, next slide, this was after the skin grafting. Next slide. Nitin?
Yes, sir.
This was the video. This is the final video. Can the video run?
Yeah.
We have the video. Yeah. This is the video. He's now walking. Basically, I feel you should never give up proper dressings. I never handled this case to any of my juniors, anyone else. I do them myself, the dressings, the debridements, and everything. Here, this is the same patient. This is after around 4 to 5 months that he's walking. First time in his
Amit, can I ask question?
Yeah, Sunil.
Does he have a pad pain?
Heel pad pain he had. he had before my surgery because of the K wires which I had put from the heel pads into the bones. That's the reason the heel pad survived. During this surgery, the final surgery of a skin graft and reconstruction and the removal of the first metatarsal removed those wires. Now he doesn't have any pain at all and he's walking well.
So because you should not put anything heel pad.
Yeah. But heel pad avulsions, generally what I do, I get these heel pad avulsions. I just put multiple K wires into from the heel pad into the bones. I do not suture those heel pads. So these multiple K wires really do a very good job. And regular debridement. This is the way he was walking. So any questions on this?
Good.
That was a
metatarsal defect is left alone, and he's still walking with a metatarsal defect, the first metatarsal.
Yeah. As Didi said, he is walking on the lateral side. The medial side, I had to remove, though I tried to keep it at. I thought a lot of things, if not a metatarsal or fibula, but then I thought again it would get infected. Why lose a fibula over there? So instead of that, I removed the first metatarsal, did a skin graft in the hope that I would do another surgery if he doesn't walk. But now he's walking, so it's not needed now.
Yes,
is there any collapse of the first tray now?
No. Now there is no collapse at all because probably I had waited for such a long time. I waited for around 3 to 4 months before doing this final surgery. So there is no collapse at all.
So how is his medial arch now, Amit? Medial arch?
Medial arch, I don't think he has any medial arch now because he has the metatarsal has been excised. And my aim is
save the foot. Yeah, agreed. Yeah, you saved the foot.
Yeah, at least the foot. Yeah, Didi. Hello.
No. How many months now totally after the completion of the
This is now 17th November 2019 was his accident. 17th November 2019.
So still long way to go because there will be collapse.
Yeah, could be. But what to do now? He's walking. There would be collapse.
Good shoe.
Yeah. Correct. That I can give.
Give him.
Now there's no wound at all.
Amit, can I ask?
Yes. I can't hear you properly. Yogesh, are you asking? Who's asking?
Yeah.
Your voice is breaking.
Amit, my question is.
Yes.
With this comminuted metatarsal fracture.
Yeah.
And as you were procedures of another, preliminary would have that pattern what you have, removal of first metatarsal.
Yes.
About the gate.
You are not audible. Actually, not audible. I can't hear you properly. Yogesh.
I'll take your question after.
Yeah.
Anyone?
Anyone else?
Amit.
Yeah. Abhay.
Yeah. So a lot of these patients have chronic painful feet. While 1 year, 2 years down the line, they are happy, grateful that their limbs have survived, but they keep coming back with painful feet. So somewhere, it's a very big debate, considering the picture on the left, screen, especially in the lower limb, it's a call we have to take, and it's not just pure science, whether an amputated prosthesis, a very good prosthesis, will serve much better functionally, because there are no deficits. So, I mean, it's a debate which can be on all the while. But considering the picture on the left and knowing it's a lower limb, and having seen a lot of the recoveries as they are on the right side, somewhere on the right side, whether to do a secondary amputation, or go and salvage. There's not a lot we can do for survived limbs. So it's always a big question mark.
Can I ask that two computers should go on to only one computer, because there is a lot of echo is there. We are not
there's a lot of echo.
So,
Abhay, I would like to answer this. Now, look, for this type of a person or this patient, life of our trauma surgeons would have been really easy if all we had to do ever is treat fractures only. But then over here, we have to treat the society, we have to treat the patient individually, emotionally, everything. When before operating the first day, I sat with the patient. Of course, I didn't do a video consent, but I told them very well that even if I try to salvage this, the limb survives. Even then, after a year, after 6 months, a year, 2 years, he may say, you will come back to me and tell me that please ampute this limb. But that is now a call taken at present. Let us see. I'm keeping that in the back of my mind, and let's hope for the best.
I agree totally. I mean, there are no clear answers and no clear solutions.
Absolutely. Yeah.
Can we proceed for the delegates' question now? Dr. Ashok will ask some questions from the delegates and will answer them among the panelists. Ashok, are you there?
I'm here.
Yeah, you can ask some questions from the delegates.
Okay, there is a question from Dr. Pradeep Kuthadia to Dr. Amit Asbabkar and the panel. Whether you recommend putting just fixator like foot frame and tibial component using long K wires. This gives good stability.
Yes, Kuthadia sir, I know, I understand. But for me, whatever trauma practice I'm doing with these external fixators, I'm not very, very familiar with just fixators. And especially in the foot area, I feel a good sturdy external fixator has to be put. And fixator is for a very short time, very temporary, just till the primary soft tissue healing or when the joints stabilize. And later on, as you saw, I have removed the fixator at an early date.
So can I also take this question?
Yes, Abhay.
Yeah. So good afternoon, Kuthadia. Hope you're good. So we've been treating some of these injuries with fixators, and our thought process is that if we feel that the foot is reconstructible, we will try and restore the length and alignment both a lateral jess as well as a medial spanning jess, and keep our minds open to putting a fibular strut and doing a fusion down the line if the soft tissue is reconstructible. So yes, we've done a couple of cases with the lateral and the medial spanning fixator, and at least 3 patients I know have done really well. But you know, their wounds have been reconstructible wounds and not as bad wounds as the case in question.
Any other question? Ashok? Hello? Is there Ashok?
Another question to the panelists: in comminuted compound open fractures, anytime when do you decide for shortening or indication for shortening?
Yes, you can take.
Yeah, so there are 2 situations where I will not hesitate to shorten the limb. One is if the patient needs a vascular repair. So the primary aim is to give the vascularity and the soft tissue structures enough flexibility and pliability to restore normalcy and restore circulation. So that is one condition where I will not hesitate to do a shortening primarily. And the second shortening is that if I have a more comminuted tibia and an apparently less comminuted fibula or a non-comminuted fibula or a non-broken fibula, then I would just go and do a small osteotomy and do a small fibulectomy so that I get a good length rotation alignment and reduction on the tibia so that my primary tibia heals. So probably those are the 2 cases where primarily I would not hesitate to do some kind of a shortening.
And the other one is the loose fragments with no soft tissue. And diaphyseal area.
Yeah, so actually this experience comes from the Ilizrovs that we did a lot of. that about 3.5 centimeters of primary shortening, there is absolutely no problem with the vascularity of the limb. So you do a Doppler and you can do a study, an angiographic study post 3 centimeter shortening, acute shortening, done in different situations, and it does nothing to the limb. But primarily, those are the three conditions probably where I would shorten it. Okay.
I think apart from those religious Elizarov or Jess external fixator users, mostly for circumferential open fractures wherein we think that plastic surgeon colleague needs to come into role, we would prefer not to use them at some sites at least. Amit, do you agree? Rajiv, do you agree on that?
Absolutely.
With that, I want to throw in a question on antibiotics. What is your opinion on choosing antibiotic or changing antibiotic from the initial regime to another? So when do you up the antibiotic? Rajiv, do you want to take this?
Me?
Yep.
Okay. So basically my starting role is very simple. Second generation cephalosporins, aminoglycosides. If it's very bad contamination, add a metrogel. I keep this. My whole idea is to get my wound debrided and clean as soon as possible. Antibiotic is not a replacement for a dirty wound. That's my answer to this question. That means something is going wrong in your debridement. You have to, if you are not comfortable enough doing debridement, get your colleague. I have Soumitra with me who comes in, need be. I get my plastic surgeon with me. My wound is not getting clean enough. So I hardly ever escalate up. Only reason I would escalate up is patient going to septicemia, sepsis, unknown cause, polytrauma, pelvic injury, associated pelvic injury. Is there something happening in tummy? That's the only time I'd escalate up. Otherwise, don't ever escalate up. I always look at my wound. My wound is a problem. Antibiotic is not the answer. Something is doing wrong in the wound. If I can't do it myself, get somebody else along with me. Get the wound right.
Okay. Any more questions from audience, Ashok?
Yes, sir. Dr. Deshpande wanted to know about the LDH protocol that Ganga Hospital is following and how to interpret it.
Did he?
What protocol?
The LDH.
Lactate.
Yes.
Oh, lactate. Okay, lactate.
Sector, we do a primary lactate levels at the day of admission. We do it on the second day or third day of admission, and we see the falling trend to get a definitive fixation as well as flap cover in the polytraumatized patients.
Okay.
Number one is in polytrauma, of course, lactate is almost always used. In open injuries also, it is also similar to a polytrauma, because polytrauma by definition, if there is a major injury of two organs, here the one is the skin is an organ and the extremity is an organ. That is, bone is an organ and skin is an organ. So it is essentially all major open injuries also fall into a category of a polytrauma. So in these instances, a lactate level, we have done a study where if the lactate is very high by third day, and then you do a flap when the lactate level is higher, we have found that the failure rates are also a little higher. So even for a flap to be done later stage, the lactate levels must be normalized. If it is normal, if it is not normalized, and then you go ahead to do a next procedure, there is going to be some sort of problem. We have found our infection rates to be little higher, and also non-union rates are higher when we did the secondary procedures when the lactate were little higher. So now the protocol that we have made is, after our initial fixation on day one, only the next procedure is taken after lactate level becomes normalized. Till that time, we don't go on to do any other procedure.
Okay. There's a question from delegates that what is the time cutoff limit of time when the external fixators are out? At what time, till what time we can put an external fixator? Some delegates are asking.
I didn't get the point.
Whenever you put an external fixator in the patients of compound fracture, at what time you will get it out? People want to get an idea about it.
No, whenever we want to revise an external fixator to definitive fixation, it is you have to go and do it. Sometimes when there is on the 3rd day or 5th day, you are inspecting the wound. If it is ready for definitive fixation, you remove the external fixator and do the definitive fixation. Only if it is beyond 3 weeks to 4 weeks, and then you see that any redness or any infection in the external fixator pin tracks, then you need to give the some sort of a window period. You remove the external fixator, wait for 2 weeks, and then convert into definitive fixation. If there is no redness, there is no infection around the pin track site, it is safer to do a conversion to definitive fixation.
Yes, Rajiv sir.
There is a study which says within 2 weeks is the cutoff period. Within 2 weeks, you can do a definitive fixation. Beyond that, the rate of reinfection is definitely higher. P-value is significant.
Okay. Yeah, that is there, but we have done our own study also. Yeah. We have found that we can stretch it up to 4 weeks. We have taken a group up to 2 weeks. We have taken up to 4 weeks, and then beyond 4 weeks we have taken. And we found that there is no difference between 2 weeks and up to 4 weeks.
Great. And the window period is 14 days, is it? Because the same article Rajiv is quoting, the window period is 7 days there.
7 is ideal.
Yeah, but Mohit Bhandari's randomized this thing, whatever his meta-analysis, he has said that 14 days is the ideal time because a lot of authors have said 14 days.
Yep.
Okay. Amit sir, you want to make a point? Unmute yourself. Amit sir, unmute yourself.
Yeah. Sorry. Generalized, I would like to ask the panelists, given a compounding injury, how much is your dependence on the external fixator vis-a-vis compared to the primary fixation or an antibiotic could nail? Sunil? Is Sunil there?
Yeah. Yes.
Sushrut, you can answer.
I think 10 years back, I used to do small compound fractures as a set from compound grade 3 and 4, wherein we need this dilemma exists. I used to do 10 fixators. Now that incidence has gone down to using maybe 3 or 4 external fixators. So I'm preferring more and more internal fixation, which is a definitive fixation. I might add a couple of screws here and there at a later date, but mostly I would go ahead with, and now this advent has happened in my practice is because of understanding of debridement and aggression of debridement, and understanding also that I need to go down midnight and do that first aggressive debridement. So with that understanding, I think my rate of external fixator application has gone down by almost 60%. You have to unmute. Amit, you have to unmute.
Unmute.
I think the external fixators in the long run, a lot of pin tract infections, whatever I've seen, unless and until you take care of the pin tracts properly. But then my threshold for putting an external fixator is too low, unless and until absolutely needed. The key is to depend on the debridement. Once debridement is done, I would, in any case, try to put primary internal fixation or an antibiotic coated nail at the most with antibiotic beads.
Yeah, great. Great. Rajiv sir, yes. Rajiv sir.
Just to answer to that, I use the X-Fix only the temporization device. Can you hear me?
Yeah.
It's a temporization device. I mean, again, the cornerstone for open fracture management is debridement, some sort of stabilization till definite stabilization. So if my biggest problem is getting my implant in on the day of surgery is a big problem, big challenge. That is the reason our X-Fix set is always ready for me. Very low threshold to put on for 48 hours, change within 48 hours to a definite fixation. So it's only a temporization device.
So are we almost done, Nitin?
Yes, sir. We are almost done. You can sum up and we can close them.
Okay, I think it was a terrific web-based discussion we all had. We understand how we should attack open fractures now. Debridement is the key, which all panelists have agreed. We know how we should do debridement, what is in and what is out. Definitely fixation is preferred way. Articular reconstruction has to be done as early as possible. With this, I thank all the panelists. Thank you, Sunil Kulkarni from Miraz, Rajiv Chatterjee from Kolkata, Amit Asgaonkar from Mumbai, Abhay Elans from Jodhpur, Anil Masad Nagpur, Din Dayalan from Coimbatore, Rajiv from Surat, Harshad from Mumbai, Yogesh from Chandrapur, Dr. Mahendra Kale from Akola. And thanks ever so much to Dr. Ashok Shyam to put this all together. Thank you very much. Appreciate your efforts. And thanks Nitin Kimmatkar, the would-be Secretary of VOS, for an excellent moderation of the entire program. See you guys again. Stay safe. Thank you very much.
Thank you. Thank you all. Thank you all.
Thank you all. Thank you.
Thank you.